Hi everyone. Today we're going to talk about mood and affect. So much of this will come as a refresher based on what you all learned in Nursing 131. Some of it will be new, but as I've said before, most of it's going to be familiar because you not only have learned about it, but you've also applied this theory to practice in the clinical setting by administering a lot of these medications. But as you learned with Lisa's teaching, some of these antipsychotics especially can have some serious side effects and terrible outcomes if we're not aware of what to look for. So let's get into it. Depression overview. Let's talk briefly about the pathophys. What is depression? It's the dysregulation of neurotransmitters, and mostly, not all inclusive, but mostly norepinephrine, serotonin, and dopamine. Okay, and so those are the neurotransmitters that we're going to be talking about most often. The brain is what most people call the last frontier. There's so much to learn about what is going on in the brain, and there's so much that we still do not know, but we know a lot about how neurotransmitters work and the pathways and how pathways have been disrupted based on many things in a patient's life and patient's genetics. And we'll get into that in a little bit here. Other etiology that I kind of just touched on for a second there is genetic predisposition and social and environmental factors. That all can contribute to a patient's likelihood for depression. All right, so within depression, let's talk about affective disorder. Like I said, I know that a lot of this is already very familiar to you. But affective disorder is a patient that presents with a depressed mood, despair, insomnia, loss of interest in normal activities that used to bring them interest, used to excite them, things they used to look forward to. When they're experiencing more fatigue than usual, decreased ability to think. All of that, with the exception of this last point, you're probably all thinking, my gosh, that's what I feel every day. I'm in school, I work full time, I have a family to worry about. So you may not be experiencing depression. It might just be extremely situational for you. But all kidding aside, clinical depression absolutely needs to be addressed. And hopefully, especially when our patients are coming in, we can address that in our admission assessment. And thankfully, just in the past, really probably 5 years, we've included the suicidal assessment as well in the admission assessment. And one of my patients, that's not true, one of my students, we had time. I don't typically have a student complete an admission assessment independently, but she did. And she was really proud of herself because it's lengthy, a lot of questions, and she realized there's a lot of sensitive questions, especially around suicide, and they need to be asked. If I'm okay in my skin and I'm feeling good and I'm not depressed, I'm going to have no problems with answering those questions. It might be a hair uncomfortable to be asked, but we absolutely need to ask questions because we don't know. We don't know what's going on under the surface of any of these patients that are being admitted. They're completely new to us. They're complete strangers to us, and we'd be doing them a disservice if we didn't approach that subject, which obviously that's why it's been woven into the admission assessment, thankfully now. All right, so let's talk about more clinical manifestations of depression. Just to kind of expound a little bit already on what we've talked about: decreased energy, limited libido. That's very important. It should be very important in most people's lives. Sleep disturbances, that's critical. If I'm not getting sleep, I'm not going to be 100%, not even close to do my job well, be a good mom, be a great friend. Excuse me, the list goes on. When you have lack of sleep, you get more sick when you don't have a good night's sleep. Decreased ability to perform ADLs. When you find yourself sitting on the sofa all day long and you just want to play games or you just want to Netflix binge, and there goes the day, and days turned into weeks and weeks turned into months, we might need to address Does this person have depression? Obesity, I'm eating more. Some people cope with eating, some people cope by not eating at all. But we see more obesity than anorexia. It depends. You guys learned that in 131. Not always textbook. So coping mechanism, ineffective coping, we can see obesity, we can see anorexia. Alcoholism, drug dependence. We went from what were our good habits that we replaced with bad habits, and then going back to the neurotransmitters, going back to your dopamine response, your norepinephrine, your serotonin response. We just legit redirected. We created new pathways in our brain and how we cope. And for anybody that's been to rehab, worked in the clinical setting with me at Commonwealth even, they teach them on how we can basically reprogram their brain. Kind of, they want to be rewired. The patients say, I want to be rewired. I want to learn new ways of coping. And that's just what it comes down to. And that's non-pharmacologic, but of course, I'm talking about the pharmacological ways that we can help our patients. Hopefully temporarily, hopefully short term. Okay, so much, if you guys haven't already listened to the stress and coping, I always weave in whether it's the nutritional or the herbal aspect that complements our pharmacological ways and treatments of any of the issues or disorders or diagnoses that these patients have. And you'll also see that on the NCLEX. You'll see the herbal components, you'll see the homeopathic components. So within this lecture, we're going to talk about St. John's wort. Many patients take St. John's wort. It can decrease the reuptake of the neurotransmitter serotonin, norepinephrine, and dopamine. Okay, so it can decrease the reuptake of the neurotransmitters, and that essentially means here's serotonin floating around, here's norepinephrine floating around, here's dopamine floating around between the synapses, right? And if they're reabsorbed pretty quickly, all right, so the brain, how can I put this in a really simple way just to kind of bring back what you learned in 131? The brain kind of kicks out any of those neurotransmitters. And most of them are feel-good chemicals, all right? Feels good. And with some of our brains, especially those that are more, have greater tendencies for depression, the reuptake, the reabsorption is very quick. So most of the meds that we're going to talk about and these herbal aspects here, they stop the reuptake. They let those chemicals float around longer so the patients can feel better. So it doesn't stop the reuptake. That would be super contraindicated, but it just slows the reuptake. It slows the reabsorption between those two synapses, and so that the serotonin, the norepinephrine, and or the dopamine floating around between those two synapses can make you feel better longer. Hopefully that makes sense. But we're going to talk about St. John's wort to come here on how it is contraindicated if patients are on any other of these meds here. We'll talk about that in a minute. Ginkgo biloba, very common, may increase energy levels, fatigue, lethargy, poor concentration, may improve disrupted sleep patterns. Ginkgo really helps with sleep. I say better than melatonin as far as what the research says. May improve or under-eating over or under eating linked to depression. All right, so that goes back to the obesity versus the anorexia, and ginkgo really helps with that. It's a tried and true herbal supplement that's been used in the Eastern world for thousands of years. Again, we just have to be mindful if patients are on any more of our conventional medication so that it's not contraindicated. Sleep patterns, just a little plug for magnesium. I think I've talked to you guys about magnesium. I just talked to a friend about magnesium yesterday. They have been having issues with sleep. Now, granted, talking to them, they have a lot going on in their life, but magnesium definitely helps. Sorry, that's just a little side PSA. And most of us don't take enough magnesium in our diet. Magnesium helps so many different things, but definitely sleep. So that was just a little plug for magnesium there. All right, so we're going to talk about major depression and how we treat it and the action of antidepressants here. So most work by affecting changes in the brain chemistry and communication and brain nerve cell circuitry known to regulate mood. And I just talked about that. Synapses fire, And there's some dopamine hanging out kind of in that middle space before it's sucked up by the other synapse, reuptake, reabsorption, call it what you want. So this kind of makes sense, hopefully based on my layman's description of what happens with synapses and the neurotransmitters between it and how it affects our brain, how it makes us feel. All right, so we're going to talk about serotonin syndrome real quick, and then it's going to be kind of woven through, unfortunately, the probability or the potential ADR for some of our antidepressants here. So serotonin syndrome, what is it? It's the overactivation of serotonin receptors. It's a rare and life-threatening event. When our patients start a certain medication, we're going to talk about some that have a higher probability for serotonin syndrome. When we start those medications, it can occur, we can look for it to occur between 2 and 72 hours after initiation. All right, this is especially prevalent in psychiatric, especially emergency psychiatric. I saw it once when I worked in CPEP for a few years there. It's not common, but it is extremely serious in how we handle it as well. So what's the cause of serotonin syndrome? A couple different reasons why we might see serotonin syndrome. The dose might be too high for an antidepressant that we start. There are definitely med interactions or with combinations, especially SSRIs if we start those in combination with coming off maybe a MAOI or vice versa, or a new treatment of a substantial increased dose. If patients are just not improving, their mental state's not improving, they're maybe even getting worse. You'll learn as I go through this that it takes weeks sometimes to really notice a change in your mood and your behavior, your quality of life. If we've given this 4 weeks and patients are either just the status quo still or declining even more, then you will see an increase. We'll see a doctor or psychiatrist increase the dose, and every once in a while we'll see the likelihood of serotonin syndrome because of that. So that's definitely something to be aware of. All right, so symptoms. What are the symptoms of serotonin syndrome? This is nothing new to you guys, but I know you have so much going on in your life, and maybe you don't remember serotonin syndrome, but the symptoms of serotonin syndrome: agitation, confusion, restlessness, diaphoresis, fever, tachycardia, hypotension, muscle rigidity, sluggish pupils, tremors, tachypnea, hypersalivation, and the worst of it, and I have a kind of a neat chart later in this lecture too that kind of reflects this. The most severe case is coma and death. So you can see it's very, very serious. Alrighty, so the first antidepressant that we're going to talk about are the SSRIs, selective serotonin reuptake inhibitors. Again, it's inhibiting to a certain level the reuptake of serotonin. All right, the prototype that we're going to talk about is fluoxetine, better known as Prozac. So the indication for Prozac, and it has been for a long time, is depression. It's one of those tried and true antidepressants, SSRIs. The action, it's thought to be linked to drugs inhibition of the CNS neuronal uptake of serotonin. Okay, it's very common. And it has, it's been used for so long, low dosages, because it has much less severe signs and symptoms, ADRs, than the other drugs that I'm going to talk about. It doesn't work for everybody, but it works for most. So we still see that very prevalent. My students will talk about it. What do you have there? I have, gosh, and they struggle with how to pronounce the brand, or I'm sorry, the generic. So I say, this is Prozac. And again, now I am going to whisper, because in the clinical setting, especially when we're talking about sensitive meds, whether we're talking about antipsychotics, antidepressants, and benzodiazepines, anxiolytics, cancer meds, HIV drugs, those are very sensitive drugs. When I'm approaching a patient, when I walk into a room, and I talk to my students all the time about this in the clinical setting, if there's family and friends at the bedside, I'll ask the patient, I have your medications here. Do you want your family to step out? Are you okay? You comfortable with them sitting here? Now the patient knows what they're receiving. They know they have their Prozac coming. What I don't want the student saying is, I have your Prozac and it's for your depression. And some people have Prozac ordered for other issues as well. But it regulates your moods. Saying that in front of friends or family members, it's almost like a HIPAA breach. Okay. It's that sensitive of a topic. So be mindful when you're administering any of these meds and how you deliver the message and how you talk to them, doing client education at the bedside, especially with friends and family at the bedside. All right. So with that being said, the ADRs of Prozac, serotonin syndrome. All right, and the drug-to-drug interactions, I'm not going to go into it, but most of the drug-to-drug interactions do cause CNS depression. All right, so if we're taking an SSRI with an MAOI, which we're going to learn about in a minute, I think you guys have already learned, I know you guys have already learned about it, but it's going to be a great refresher. TCAs, St. John's wort, it's contraindicated. Kava, ginkgo biloba, alcohol, other CNS depressants, it just further depresses the CNS system to where I'm walking in and I'm calling the ambulance because my family member is in bed and I can't even rouse them. All right, so nursing assessment for Prozac. What I'm going to talk to them about is what medications are they already taking. So that's your medication reconciliation. Medical history, including herbals. Always include and ask about the herbals. That's one thing at Crouse and some other hospitals that I've worked at that I think we're still kind of falling short on is the homeopathic remedies that these patients are taking at home, the herbals. We don't ask, we just don't think that, well, herbals are harmless. They're not when they're being taken with other medications at times here, especially the conventional meds that we're giving. Review history of depression. Ask about suicide. Like I said, the admission assessment already weaves in the suicidal assessment, ideations. Assess for mania. SSRIs given to adolescents with severe depression can increase suicidal thoughts. For some of us that still watch TV and still catch commercials, and I say this to you guys all the time, I'm covering prototypes, but there are so many medications out there, and any of the content that I'm speaking on, especially antidepressants, there are so many antidepressants. I watched an antidepressant commercial the other day, was not familiar with it. It's just the next big antidepressant, and of course, the second half of the commercial was all on it can cause suicide, it can cause this, it just horrible things. And I'm thinking, my goodness, anybody taking this for depression, it's shocking. It's surprising that it actually can cause suicidal thoughts. So for Prozac, it can increase suicidal thoughts for adolescents if Prozac is being ordered for somebody in the adolescent age group. So client teaching, of course, it's going to cover that. Also observe for worsening suicidal behaviors and change in mood in any of our age population here. Signs and symptoms of serotonin syndrome. Common side effects that we would accept. Just going to take a drink of water real quick. Headaches, insomnia, anorexia, you would hope that eventually would help a patient get a better night's sleep, but with Prozac, we take the risk versus the benefit. Sometimes they don't get great night's sleep. They feel a lot better during the day. It can cause anorexia. Some patients who were looking to lose weight, so to speak, I've had many patients say, I loved being on Prozac because I lost 20 pounds in the first 6 months that I was on it. Now, that's not necessarily what we want to hear, but we do see anorexia with some of our patients. They just have no appetite and they're not eating at all. Take drug in the afternoon. That just goes to, it can increase the CNS effects, and you want them kind of taking that. The first 12 hours especially, they can feel a little drowsy, so hopefully that's when they're sleeping. But on a 24-hour basis, it's hopefully improving their moods. And we want to assess for the full therapeutic effect. We want to see them feeling better. And like I said, it can take up to 4 weeks work to help a patient feel better. And so sometimes we'll see compliance issues with that because they take it for 2 weeks, which feels like an eternity to them because they're looking for that. They're just looking to feel better. I'm not saying they're looking for a quick fix. They're just looking for their life to feel better, be better. And 2 weeks feels like an eternity to them, and they stop taking it because it didn't work. So we need to really bring home to them that, you got to give this I tell patients even up to 6 weeks, you got to really give this time to work, okay? And then after that time, if we don't really see any significant difference, we'll try a different one, okay? And in the meantime, again, we'd be remiss if we weren't looking at the patient in a comprehensive way. It's not just let's throw medication at them. If it is a situation where they're under extreme stress, how can we help them decrease that stress in their life? If it's a situation with PTSD, maybe they need therapy. Not even maybe. I think everybody really needs therapy at one time or another in their life. But therapy, exercise, healthy diet, I'm teaching pharm, but I need to, I wouldn't be doing any of this, a service if I wasn't covering the whole picture. This is a patient who's struggling. This is a person who's struggling, and how can we help them without judging them? Some patients say, I can do this on my own. I don't need medication. Well, in many situations, they do need a medication, if not for just short term. So again, I think that goes without saying as well. But going back, even the common side effects, the headache, the insomnia, the anorexia, oftentimes that's just short term. If patients are taking Prozac for a year or more, those side effects, those common side effects typically go away. All right, so the next antidepressant that we're going to talk about, we talked about SSRIs. Now we're going to talk about SNRIs. So serotonin, norepinephrine, reuptake inhibitors. Okay, so it's inhibiting both the reuptake of both serotonin and norepinephrine. So we're talking about two neurotransmitters in one for this medication. And this medication, this prototype that we're going to talk about, is venlafaxine, better known as Effexor. And Effexor is what I would consider as one of, in my opinion, one of the most prevalent and one of the most effective antidepressants out there. Really helps a lot. I had a patient, not really mine, it was my student's patient, say recently, this saved my life, this saved my marriage. I was a better dad, for reasons that I can't go into, starting from when I was a young child. I had a lot going on, okay? And I think my brain just didn't grow the way it should have grown, and I had a lot of chemical disturbances and imbalances. When I went on Effexor, I felt like a new man. I mean, those are the patient's words, not mine. So as much as I hate Big Pharma, and I've told you guys that, you can't take that away from a patient that says that. I mean, that is their real life experience. That's their, what they call the patient experience or their lived experience. So, and I believe them. So indications for Effexor: major depression, generalized anxiety disorder, and social anxiety disorder. And that's for those folks that absolutely freeze in a social situation for, again, many different reasons that I'm not going to go into, but it's debilitating, okay? And something like Effexor can really help somebody, especially in the workplace. When when these people are working and it's affecting their workplace, how they're working, their work productivity, and we can give them a medication that can help with that, why not? So the action for Effexor increases the availability of serotonin and norepinephrine, and even dopamine. So indirectly, it affects the dopamine in that synapse area there, okay, between the two synapses. All right, and it has similar effectiveness to TCA. We'll talk about it in a little bit, but SNRIs in general are more effective than SSRIs when it comes to severe, absolutely debilitating depression. All right, so the ADRs for Effexor, I know I hyped it up, but there are some considerations to think about. We do want to kind of capture, again, talking to our patients about the possible suicidal ideations that they might experience. We want to be on the lookout for serotonin syndrome. And for SNRIs, there's a likelihood for weight gain. So while our patients love it, they don't like the weight gain. So we definitely kind of complement that, teaching about the ADRs with client education about proper diet, healthy diet, exercise, daily exercise, to try to combat that. So drug-to-drug interactions with Effexor. Here, St. John's Wort again, MAOIs, TCAs, and alcohol. So I mean, those two middle ones there, the MAOIs and TCAs being given in conjunction with an SNRI, we can really see some increased CNS effects. And just when you look at the ADRs, just take that and multiply it times 100. You know, if you're taking an MAOI with an SNRI, you're going to see the likelihood of serotonin syndrome just go through the roof. So, and they do it, it's not often, but psychiatrists do combinations sometimes based on how severe the depression is. So again, as nurses, we need to be aware of these potential ADRs. All right, so the nursing assessments, it's hard for me not to weave in the nursing assessments. By the time we get to these slides, you're probably like, goodness, this is so redundant. Medication history, including herbals, social history, including alcohol and recreational drugs. As far as client teaching goes for our SNRIs, and what we're talking about Effexor here, we need to let them know not to abruptly stop this drug. Monitor for the signs and symptoms of suicidal feelings, ideations, mood changes, signs and symptoms of serotonin syndrome. You want to encourage them to take with a full glass of water. All right, and let them know that Effexor is extended release too. And it reminds me of when I was teaching on stress and coping. Patients who pop Xanax, like it's Tic Tacs. I know Tic Tacs aren't super common anymore, but in my day, you had bad breath, pop a Tic Tac. But anyway, so that's where that phrase kind of comes from, because people were always popping Tic Tacs. So, Xanax, they pop Xanax like Tic Tacs. And then, for some of our antidepressants, I take them in the morning, I'll take another one at night. Let them know it's extended release once a day. All right, moving on to mirtazapine. We just talked about our antidepressants, SSRIs and SNRIs. Now we're going to talk about atypical antidepressants. And the prototype we're going to talk about is mirtazapine, better known as Remeron. It's the brand name. Indication for Remeron, major depression. All right, and the action, I hate when we have to put this, but here again, it's the brain. I'm not a chemist. I don't work for Big Pharma. I don't work for Pfizer. I don't know what these guys or girls are doing in these labs, but what we do know is the exact mechanism of the action of Remeron is unknown. All right, atypicals in general do not fit into the other classes of antidepressants. They're unique. They work in different ways from one another even. And typically, atypical antidepressants, Remeron in particular, it's used when others don't work. All right, so we do see Remeron. It's disheartening for me because I think, oh, this poor patient has tried probably many other antidepressants before they're taking Remeron. And the downside of this, and I'll talk about it in the next couple of slides, is while we don't know the exact mechanism, we do know that it causes more sedative effects. So let's skip to the next slide here, not based on that, but while we're talking about that. So the ADRs for Remeron, similar to our previous ones, suicidal ideations, serotonin syndrome. With Remeron 2, though, we'll see agranulocytosis. I know you guys probably already know what this is, but that's a condition involving serious or dangerous leukopenia. What's leukopenia? I know you guys know that. It's lower white blood cell count, most commonly neutrophils. And so all in all, Remeron can cause neutropenia. All right, so that's just good to be mindful of. Drug-to-drug interactions with Remeron, with our MAOIs, St. John's Wort, and alcohol, going back to the CNS effects. It sounds depressing just even talking about this, but we have to talk about the ADRs, we have to talk about the drug-to-drug. Overall, we are crossing our fingers and hoping it helps a patient feel better. So nursing assessments when our patients are on Remeron, medications including herbals, social history including alcohol and recreational drugs, client education, signs and symptoms of serotonin toxicity, reporting signs and symptoms of infection, reporting mood changes, suicidal ideations, administration, take drug at bedtime, do not crush or split, do not abruptly stop. All right, going back to Remeron. Is Remeron, did I talk about that being extended release? I think I did. With any of our extended releases, you guys, be aware that if you crush an extended release medication, you can, sorry, I'm just adjusting myself. You can increase the effective toxicity pretty quickly. So if crushed, it could reach a toxic effect essentially. So good to be mindful of. Okie dokie, let's go on to talking about our TCAs, tricyclic antidepressants. And the prototype we're going to talk about is amitriptyline, also known as Elavil. So, indication for amitriptyline, major depression and agitated depression. Depression doesn't just look like somebody who is sullen and lying on a sofa all day. Okay, depression can come in anger as well, agitation. All right, and Elavil is very effective for that type of behavior when we identify that that's the type of depression that somebody might have. And oftentimes that goes with depression, with a history of PTSD that might have some underlying anger issues. All right, this is the drug of choice for adolescents. For me, I feel like you just need to fill in the blanks. These poor kids, talk about environment, talk about acting out, behavioral issues. So, you know, when I worked in CPEP, I wanted to save the world. And that's not reality. Unfortunately, we can do what we can do. You guys are entering into what I consider the best profession in the world. But, you know, you can never, somebody that taught the students and I, actually this past summer, you can never determine your success by the success of the patient, okay? Basically, if the patient's getting better, that's awesome. If they're not getting better, they're not feeling better, they're not compliant with their plan of care, you can't determine your success and what you did and how you taught that patient based on what they do, okay? Because a patient still has choices. They're still going to make choices. So I know that was another little public service announcement there, but we just can only do our best, all right? Looking at these situations, especially with adolescents, especially when you guys go over to Golisano, or if you work in the peds at Upstate Psychiatric, or if you work in CPEP, or if you work at Hutchings and deal with pediatrics and the adolescents, it's heartbreaking because you look at their family life and you look at their environment, and but you know, they're oftentimes not doing well in school. And sometimes something like an Elavil does help, okay? And what is the action? It blocks reuptake of norepinephrine and serotonin in the brain, and it blocks histamine receptors as well. Therapeutic effect: elevates the mood, increases interest in ADLs, it decreases insomnia. We'll talk about the ADRs of Elavil. Yeah, I was thinking too, you know, one thing I didn't say about Elavil, I mean, when I say Elavil, I don't automatically think a TCA or tricyclic antidepressant, even though it does absolutely help with that. A lot of our patients in the hospital, just to give you a heads up, do take amitriptyline. And they're not taking it for depression. They're taking it for nerve pain. They're taking it for fibromyalgia. They're taking it for arthritis. So that's also something to really consider when you're talking about these meds. You know, I've talked to you guys about off-label. So say Elavil was initially prescribed as a TCA, and then we found that it helped with nerve pain. Awesome. That would be off-label. But in this situation, actually, it's not off-label. So Elavil is prescribed for nerve pain, arthritis, and also it's considered a TCA, obviously. That's why I'm teaching about it. So ADRs to consider when patients are taking Elavil. Very different than some of the other antidepressants that we're going to be talking about. This really hits the cardiovascular, all right? The potential for patients to have cardiovascular effects is much higher when taking Elavil than any other antidepressant, all right? And what kind of things could possibly happen, unfortunately? MI, stroke, thrombocytopenia, hypoglycemia as well. All right, and drug-to-drug interactions. I mean, I even had in italics, many medications. Every time I teach this, I'm like, you know what? Maybe I'll list it out. Maybe I'll list it out. And every time I look at the medications that interact with Elavil, the list, no joke, is like 30 well-known medications. So I just can't. It would be exhausting. It's an exhaustive list. I'm not going to bug you guys with that, but just we need to be mindful. Very effective drug for severe depression as a TCA, but be mindful of cardiovascular effects. So you guys, I think, probably know where I'm going in the next slide here. But going back to drug-to-drug interactions, also with Prozac. All right, so we don't want to be taking Elavil, a TCA, with an SSRI, Prozac, an MAOI, we haven't talked about yet, and definitely alcohol, again, going back to the CNS effects, okay? Yeah, drug to drug for fun. I mean, looking at a list that I made: oral anticoagulants, Zantac, sympathomimetics, clonidine, hypnotics, barbiturates, antithyroid meds, and that's just a lot of cardiovascular meds. All right. So nursing assessment when our patients are on a TCA, specifically Elavil, we want to get the history, their medical conditions. All right. History of cardiac disease, recent MI, current meds, many drug interactions, alcohol. How are their current vital signs? Again, going back to the cardiovascular effects of that. We got the BP. If the patient's coming in with very high, blood pressure, and this is already possibly going to cause stroke or MI, we need to be aware of that. All right. So client education, common side effects, weight gain, unfortunately, orthostatic hypotension. So you could have actually we sometimes see hypertension and hypotension with this. Dry mouth. We want the patient to report any signs and symptoms of serotonin toxicity and to make them aware that the clinical response on this can take really up to 4 weeks. I have 2 to 4 weeks, but really up to 4 weeks. And also with this one, we're going to be taking it bedtime. So going back to orthostatic hypotension, again, we just want to include, because that might be a foreign language to them. You might experience orthostatic hypotension, and they just nod, but they have no idea what you're talking about. So you have to further explain that's just low blood pressure, especially when you're laying in bed and you sit up abruptly and you feel so dizzy. Just give yourself a minute on the side of the bed before you stand up to walk so that you're not falling, okay? So that's the kind of pitch that I would give. That's how I would describe it to our patients. Alrighty, so MAOIs. We're going to go on to what we've kind of touched on. You guys are already familiar with MAOIs, but what are they? Monoamine oxidase inhibitors. The prototype that we're going to talk about is phenelzine, also known as Nardil. I don't see MAOIs in the hospital often. I'm not sure why. But regardless, the indications for depression not controlled by other antidepressants. Action irreversibly inhibits the MAO, all right? And that's monoamine oxidase. It's an enzyme found in nerves and other tissues. And MAO inactivates norepinephrine and dopamine in the brain. So that's kind of going back to it, how it works. All right, so the ADRs on Nardil. With ADRs on Nardil, the biggest thing that we can see kind of reminds me of our previous one on our TCA, but we'll see hypertensive crisis, all right? But a little side note, we can see hypotension sometimes with our MAOIs as well. But our biggest focus is going to be on the likelihood for hypertensive crisis, all right? That's when the hypertension, the blood pressure is so high that we start to throw the organs into failure, all right? If you guys have not already had patients in clinical with hypertensive crisis, we're talking 200, 220, 240 over 120, 140 for a lengthy amount of time, and it throws the kidneys into failure. It can throw the liver into failure. All right. So contraindications and cautions, naturally, if you have a patient taking Nardil, is we need to be aware of hypertension, the drug-to-drug interactions, food interaction, insulin, oral anti-diabetics. All right. I think we're going to talk about that in a minute here. Yes. Okay. So, nursing assessments for our patients on NARDL. And this is one that I think you guys remember because I did teach 131 a couple of years ago, and I do remember teaching my class on this. So I know you guys had this content already, but we need to be aware of the vital signs. Again, going back to the blood pressure. The common side effects, though, here again is that not really paradoxical, I shouldn't say that, but we could see either or. Mostly we'll see high blood pressure, but you can have a patient, and again, it's in your textbook, you'll see it in your not up to date, but the point, when you're doing your questions, you can see most commonly high blood pressure, but you can also see orthostatic hypotension as well. So it's good to let the patients know that we may see either or. And the biggest thing about MAOIs is the tyramine. All right. If they're eating foods or drinking certain beverages that are high in tyramines, we can create a tyramine response, which just blasts that blood pressure right through the roof. So if they already had a high probability of high blood pressure, and then we're eating foods, if I'm taking an MAOI, specifically NARDL, and I'm eating foods high in tyramine, I can create a tyramine response, and that's not good. So what are the foods high in tyramine? Aged cheeses, wine, coffee, I'm going to say sourdough. I talked to you guys at the beginning of this course about sourdough. And the biggest fad, it's just, my sister, she just loves making sourdough. Everybody's making sourdough now. So sourdough bread is out. All right. That's high in that's high in tyramine. It's really just the yeast, the aged, the smoked meats, chocolate, raisins, fava beans are high in tyramine. Who eats fava beans? Not me, but maybe somebody does out there that we need to educate on. Liver, I love liver and onions and bacon, but that's a big no-no. High in tyramine, pickled foods as well. Again, that kind of goes back to the aged, the souring of things, the fermentation, the yeast that goes along with that high in tyramine, usually very good for you, but if you're on an MAOI, it's out. All right, so is that the last one we're gonna? No, maybe not. All right, so another mood stabilizer that we're going to talk about, antidepressants. Some people may consider it, but it's classified as a mood stabilizer. The prototype is lithium or Lithobid. All right, and the indication for lithium. It's the first drug to manage bipolar affective disorder. It came out a long time ago. And what does it do? It alters sodium ion transport in muscle and nerve cells, increase receptor sensitivity to serotonin, depletes sodium. And because of that, we're going to talk about the labs in a minute here. All right, so essentially being a mood stabilizer, it regulates the mood thinking, regulates behavior. If patients were suicidal, sometimes psychiatrists will order lithium, and it significantly decreases their risk for suicide. All right, so the ADRs for lithium, though, lithium toxicity. All right, and unfortunately, that is more common than we'd like to say. Lithium is so effective in stabilizing somebody's mood, but not to a fault of their own, they can become toxic. All right. And I think I have a slide on this, but if not, what are the signs and symptoms of lithium toxicity? Muscle weakness, lack of coordination, vomiting, diarrhea, tremors, twitching, lethargy, polyuria, mental confusion. All right. So that's good to know about lithium toxicity. And because of that, when patients come in and they've been on lithium, usually with their initial labs, we'll get a lithium level. And a need to know for this medication is the lithium serum range. Okay, so the therapeutic serum range is from 0.5 to 1.5. Okay, and levels greater than 1.5, especially to 2, are toxic. We don't usually see levels that are very, very high. And so what could cause toxicity? Maybe the dose is too high. Maybe they are going into some kidney damage for other reasons. Maybe they're older and they've been on lithium for a long time, and we start to see a decrease in renal function. And so that would, naturally cause a higher level in the bloodstream and make them toxic. When patients are initially started on lithium, their blood draws are done biweekly until the therapeutic level is reached, and then monthly. And then sometimes it goes to just Q6 months. All right, so, and just keep in mind, because the therapeutic range is so narrow, we need to really closely monitor that. So, caffeine, going back to drug interactions, why is caffeine contraindicated? Caffeine is essentially a diuretic, and if I'm drinking, that I'm drinking a lot of caffeine, which a lot of people do, including myself, probably too much caffeine. But now we have these energy drinks too that have off the charts caffeine levels. You guys, I cannot say enough. Energy drinks should be off the market. They are like what I consider a legal drug. It's awful. FDA approved, but they have no idea what's in these energy drinks. But what I do know are in them is caffeine and levels that we've never seen, okay? And it's just it blows my mind that they're allowed on the market when they have just exorbitant, levels of caffeine. But what is caffeine? It's a diuretic, so it's going to cause diuresis, which would essentially increase the lithium concentration in the bloodstream, hence making them toxic, or the potential for toxicity, right? So it's just good to tell them just to avoid caffeine, or if they're going to have it in very, very small amounts, very low levels. Okay, so nursing assessments for lithium. We want to go through their current medications. We want to get their vital signs, monitor for sodium intake because lithium can deplete the sodium. All right, we need to be aware of their fluid intake, monitor the therapeutic levels, which we already talked about, and assess for lithium toxicity. Common side effects when patients are taking lithium: dry mouth, weight gain, drowsiness, dizziness, tremors, slurred speech, vomiting, diarrhea. All right, and those are they can be common side effects. And then when you're having toxic levels, you take any one of those and intensify it by a great deal. All right, I already kind of talked about the side effects, not side effects, but the lithium toxicity effects. So increased fluids, and then of course the therapeutic blood draws. Okay, I would say the biggest thing with lithium toxicity that we see, and I've seen a few times in my career, is ataxia. It's the tremors. It's somebody coming in that is like shaking. We can't figure out why they're shaking. We go through the medication reconciliation. We do the admission assessment. Maybe they came in for another reason. We find out that they have toxic lithium levels as well. All right. So, I mean, the ataxia, the tremors, the GI effects, the vomiting, that's a big time too. They're very nauseous. So just little highlights on those. Okie dokie, another mood stabilizer that we're going to talk about. The prototype is lamotrigine, better known as Lamictal. All right, and the indication is for long-term maintenance of bipolar disease. All right, here's another one where the mechanism of action is unknown. All right, what we do know about Lamictal as well is that it's an anticonvulsant. And when you think about anticonvulsants, it's just really calming down the neurotransmitters. It's calming down the electrical activity in the brain. So I know that the box says, your drug classification would say in the mechanism of action unknown. But if I know that it's also an anticonvulsant, I know that it's decreasing the electrical activity in the brain. But indirectly, it's helping with bipolar as well because of that. So Lamictal is used long-term as well. We don't blink an eye to have these patients on Lamictal for years. All right, bipolar is a serious issue that affects both personal and professional lives of patients. So we want to make sure that their quality of life is as best as we can make it, and Lamictal really helps our patients. So indication, I already went through that. So the ADRs for Lamictal, though, again, we're going back to rash, and oftentimes we'll see, not oftentimes, scratch that. There's the probability, granted it's low, but there's the probability for Stevens-Johnson's with Lamictal as well, all right? Suicidal ideations, we need to assess for that because that's a possibility, probability. Nursing assessment, complete history, all right? We're doing the H&P. We're talking about suicidal ideations. We're assessing their skin. especially if they've been on Lamictal. Client education, just talking to the patient about the common side effects: nausea, vomiting, diarrhea, headache, blurred vision, anxiety. A lot of these are very similar along the mood stabilizer and antidepressant realm here. When patients are started on Lamictal, and we'll talk about it with our anti-seizure meds because it's very similar, the dose is titrated until it's really therapeutic, until we see an improvement, in this case, with their behavior, the bipolar behavior. And it doesn't take as long as some of our antidepressants or mood stabilizers, some of our other mood stabilizers, but it can it can take up to a week to 2 weeks with Lamictal to really feel therapeutic, to feel like we've seen a difference. And that completes our mood and affect lecture. Please reach out to me with any questions, and I hope you guys have a great day.